While everyone experiences some disruptions to their emotions over the course of their lifetime, in general, most people experience emotional homeostasis. This isn't consistently true for those who are diagnosed with a mood disorder. The DSM formally defines a mood disorder as a serious, persistent disturbance in a person's emotions that causes psychological discomfort, impairs the ability to function, or both. In this lesson, we'll explore a few of the most common mood disorders as well as some of the unhealthy actions that some people take in response to their disorder. This may be a difficult lesson for some, so if you find that you need to pause the lesson and regroup, feel free to work through this at your own pace. Depression, extreme sadness lasting several days or even a week or two, is an emotional disruption that most people will experience during their lifetime. People most often report feeling depressed after the loss of a loved one through either death or the end of a relationship, or after a change that might be sudden, such as the loss of employment. This sadness is present, but it doesn't hamper day-to-day life for a prolonged period of time because the depression is usually associated with a specific event or situation, and once that situation begins to resolve, the depression lifts. However, clinical depression or major depressive disorder is a condition in which a person experiences prolonged hopelessness and lethargy until eventually rebounding to normality. Clinical depression can last for weeks or even months. Since it's characterized by extreme fatigue and lack of motivation due to feelings of hopelessness or worthlessness, major depressive disorder can dramatically affect a person's life. It can make it difficult to concentrate and thus to work. In the depths of a depressive episode, a person can feel so alone and hopeless that basic hygienic tasks, bathing, eating, changing clothes, can seem like just too much to do. People who live with untreated major depressive disorder may start to disengage from their daily life when starting to experience a depressive episode. They stop wanting to meet up with friends and/or family. They stop doing the hobbies and other activities that they normally enjoy, and they have a difficult time even remembering what happiness or contentment feels like. There are physiological effects as well. While it seems logical that the extreme fatigue that accompanies clinical depression would lead to sleepiness, in fact, those living with major depressive disorder often experience extreme insomnia. Digestive problems are also common, and depending on that manifestation, these issues can lead to weight gain or weight loss. At the same time, there is an increased risk of heart disease and general inflammation of body tissues. As with anxiety disorders, the effects of living with mood disorders are not just associated with the brain, but with the rest of the body as well. Dysthymic disorder, or persistent depressive disorder, is a less intense and more common diagnosis when compared to major depressive disorder. It is defined as having a persistent low mood for a prolonged period of time, years, as opposed to weeks or months. Like major depressive disorder, dysthymic disorder is a chronic illness, and it usually develops in response to a specific stressful event or trauma. People diagnosed with dysthymic disorder usually have milder depressive symptoms than those who live with major depressive disorder. These symptoms do not necessarily interfere with their ability to function. A person with dysthymia may be described as gloomy or pessimistic, but otherwise well-functioning. That said, it is not uncommon for people with persistent depressive disorder to experience an episode of major depression occasionally, in which case they do experience significant limitations in their everyday lives. Unlike other depressive disorders, seasonal affective disorder, or SAD, is geographically constrained. It is most prevalent in areas of the world where the amount of sunlight available at certain times of year is greatly minimized. So, for instance, the late autumn and winter months near the North and South Poles may trigger SAD. Occasionally, SAD is also triggered around time changes in states that spring forward in early spring. SAD is a very common disorder and is characterized by symptoms of mild depression such as fatigue, hopelessness, and social withdrawal. Because SAD is tied to the seasons, it is a chronic condition. At the same time, It's one of the most easily treated of the depressive disorders, since light exposure therapy, especially light that mimics that of the morning sun, is a successful therapy for SAD. A less common depressive disorder than either major depressive disorder or dysthymia is bipolar disorder, which used to be called manic depressive disorder. Bipolar disorder is episodic. This means that people diagnosed with bipolar disorder spend most of their time in a non-bipolar episode, but when they enter an episode, they alternate between depression and mania. The current DSM distinguishes between two types of bipolar disorder. People diagnosed with bipolar 1 alternate between depression and mania, an overactive, hyperactive state in which individuals may even experience short-term hallucinations or delusions. Sometimes, people diagnosed with bipolar 1 require hospitalization, usually to treat the symptoms of the manic episode, which may become psychotic. A bipolar 2 diagnosis means that, during a bipolar episode, an individual experiences a major depressive period lasting at least 2 weeks, and then a shorter hypomanic episode, where hypomania is a less intense form of mania. Hypomania includes excessive energy and focus, but does not include the hallucinations or delusions that sometimes accompany a full manic episode. People diagnosed with bipolar 2 do not usually require hospitalization. In people with bipolar disorder, an episode may be triggered by what most people would call regular and normal life events, such as a fight with friends or the change of seasons. An episode can also be triggered by medications or by changes in behavior, like overindulging in controlled substances during holidays or vacations. If a person is undiagnosed or off their regular medication for bipolar disorder, then the ensuing episode can be extreme and can significantly affect their life. If we consider mood as a spectrum, the various mood episodes and disorders we've explored in this lesson so far give us a sense of that spectrum, which can be imagined as the spectrum of visible light. At the dark end, where people feel the most hopeless and lost, you place major depressive disorder. At the light end, where people feel the most hopeful and happy, you place mania. When people feel their most helpless and lost, which can be an effect of a diagnosed mood disorder or which may be in response to a specific event or trauma, they sometimes take an action that would otherwise be unthinkable. The next few minutes of this lesson will consider suicidal ideation. Remember, if you feel the need, take the time to pause and regroup. The concept of suicide, the action of taking one's life, has a long history in the historical record. As might be expected, different cultures have regarded suicide differently. Cultures who practice one of the Abrahamic faiths, Judaism, Christianity, and Islam, generally view suicide as an offense against God. Ancient peoples of the Mediterranean basin, as well as some cultures in South and East Asia, have viewed suicide as a potentially honorable act if the alternative, continuing to live, was somehow the betrayal of an oath or a promise. Generally speaking, however, most cultures have viewed suicide negatively. As we've come to understand the connection between mental illness and a behavior like suicide, it has been possible to research the ways in which people who are contemplating suicide may behave. The warning signs of suicide generally correlate with the symptoms of depression, but can escalate with actions such as the giving away of belongings, or the making of a will, or a sudden intensification of other depressive symptoms such as hopelessness, or the exhibition of more manic symptoms such as reckless behavior. At times, people experiencing suicidal ideation may even make a statement about wanting to die, or say that they have a plan for dying by suicide, and they may even pass these statements off as jokes. For these reasons, if you notice that a friend or acquaintance is exhibiting these sorts of behaviors, it's important to take the time and ask if they're okay, and to listen carefully to their response. It's important to take any conversations about suicide, even if your friend claims to be joking, seriously. It's important to help them seek help. It might mean staying with them as they make a phone call to a helpline, or it might mean that you find someone, a counselor, a parent, who can help. It's also important to know that some populations struggle with suicidal ideation more than others. In the United States, LGBTQ youth are most likely to attempt suicide. This is probably because these youth are struggling not only with the typical psychosocial and developmental changes of adolescence, but may also be struggling with social and familial acceptance, and maybe even with their own acceptance of self. So, again, it's important to notice when friends are struggling, when their behavior changes suddenly, when they make comments about suicidal ideation. And if they ask for help them find it. If they don't ask for help but are talking with you about it, help them find help. Fortunately, there are many organizations whose focus is mental health and suicide prevention. These organizations currently on screen all work with the American Foundation for Suicide Prevention. Feel free to take a screenshot or save the numbers into your address book. But even if you don't do so, remember that you can help. If you notice that your friend or acquaintance is acting differently and seems depressed, if they're suddenly engaging in reckless behavior, or if they make comments that indicate to you that they may be considering suicide, ask your friend how they're doing. Let them know that you've noticed they're having a hard time and that you care, and help them connect to someone who can help them. In the same way that some maladaptive behaviors may seem more prevalent in certain populations, it's also true that certain populations are more likely to be diagnosed with both mood and anxiety disorders. In this way, gender, and perhaps more specifically gender bias, may play a role in why women are more likely to be diagnosed with a mental illness. With the exception of substance abuse, it is more common for women to be diagnosed with mental illness. While men and women and all genders in the identity spectrum often experience similar stressors, such as finding and maintaining a job, finding a long-term partner, becoming a parent, and caring for an ill friend or relative, it is also true that in many societies, women are not compensated monetarily at the same level that men are, and women are more likely to bear the brunt of parenting and caring for ill relatives. This social disparity may be the cause of some disparity in diagnosis of mental illness. It's not to say that men don't experience mental illness at the same rate, they're simply less likely to be diagnosed. Now, just as is true of the anxiety disorders, researchers consider multiple perspectives in an effort to understand why mood disorders develop. Unlike anxiety disorders, some of which potentially have a strong learning component, mood disorders generally have a strong biological component, although, given the role of cognition in determining emotion and thus mood, there is a learning component present as well. For instance, someone who perceives negativity in the aftermath of a stressful or traumatic event may label the emotion they feel sadness, and prolonged sadness leads to a depressed mood, which then engenders behaviors that an individual might associate with sadness or depression, which then compounds the depressive mood. So, mood disorders may be learned behaviors. At the same time, there are real and measurable disparities in the brain chemistries of people who live with mood disorders when compared with those who don't. When brain chemistry is imbalanced, and specifically when norepinephrine, serotonin, and dopamine are not in balance, the neurotransmitter that is available disproportionately may be the cause of a mood or anxiety disorder. People living with mood disorders have to find ways to validate what they're feeling, but also to recognize when they may need the additional help of psychotherapy or biomedical interventions. We'll explore therapies for mood disorders in an upcoming lesson.